The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of HFMA. The topic for today's webinar is Health System Success Strategies under Alternative Payment Models. For today's presentation, I'd like to welcome two guest presenters, Bruce Johnson and Dr. Michael Robertson. Bruce is a shareholder in the healthcare law practice of Polsinelli, PC, a national law firm with over 850 lawyers in more than 20 offices across the United States. Bruce brings more than 27 years of legal and management consulting experience to his healthcare organization clients, including hospitals and health systems, medical groups, physicians, and other healthcare enterprises. Bruce works with healthcare organizations across the nation to craft innovative relationships to promote business objectives and compliance in today's rapidly changing healthcare payment and delivery environments. I also like to welcome Dr. Michael Robertson, who is currently the Chief Medical Officer at Covenant Health Partners, a clinically integrated network organization dedicated to improving patient outcomes through the utilization of evidence-based pathways and best practices, while also reducing the costs of healthcare to patients and third-party payers. He also serves as the CMO of Covenant ACO, an accountable organization participating in Track 3 of the Medicare Shared Savings Program. In his role as CMO for both organizations, Dr. Robertson is responsible for improving the quality of care and reducing the overall cost for Medicare and other populations through various means, including care coordination, goal setting, health coaching, and population health management. So without further delay, I'd like to hand the call over to today's guest presenters, Mr. Robertson and Mr. Johnson and Dr. Robertson. And I believe, Mr. Johnson, you're up first.
Thanks very much. Thanks, everybody, for joining in today. It's a pleasure to be here. I'm really happy to be able to provide this presentation with Dr. Robertson. He's the CMO of Covenant Health Partners and Covenant ACO in Lubbock, Texas, and I've been privileged to be able to work with those organizations for 6 or 7 years now. And I'm thinking that you're going to find this this presentation, this webinar, to be really insightful and useful to understand some really great strategies that health systems have been developing and are using to deal with alternative payment models today. Let's advance the slide. My slide is not, oh, here we go. There we go. All right, sorry about that. So our agenda today is I'm going to quickly go over just some background information on the quality payment program established by the Medicare Access and CHIP Reauthorization Act, or also known as MACRA, and specifically the alternative payment model component of that and some of the essential concepts in that. Then I'm going to turn it over, and Dr. Robertson's going to talk a bit about some of the experiences and practices of Covenant Health System as it relates to population health management, clinically integrated networks, and how their initiatives align with the emerging alternative payment models that CMS is looking for, as well as other initiatives. Then we're going to flip it back to me for a few minutes on future strategies for the remainder, and we'll move into questions and answers. So just by way of background, healthcare in 2017 and 2018 on the horizon, it's just as crazy as it's been the last few years. But we are clearly in the midst of what I'll call the volume to value migration strategy that has been reflected in healthcare payment policies at the national level, and also in many states and with commercial payers. Clearly under the Medicare program, the hospital value-based purchasing program that imposes penalties on hospitals based upon their performance, that is a significant program that is getting the attention, so to speak, of hospitals and health systems around the country. And then we've got the quality payment program, which really implements under MACRA many of the same types of changes to try and improve quality and value in healthcare services. These two programs and others in other components of the delivery system are clearly institutionalizing this concept of value-based payments. And then of course, in today's environment, we have some uncertainty regarding coverage in terms of the Affordable Care Act and the Medicaid expansion programs, whether or not that's going to last long term, whether it's going to last into 2018, what's going to happen to the individual marketplace and such. I think overall, all of these different initiatives, I see a couple of themes. One is that patients that didn't have care before, many of whom are now very interested in continuing to receive care. And second of all is that public and private sector payers are really wanting to focus on improving quality and reducing cost, and in many respects pushing risk onto providers and provider networks. And all of that is occurring in an environment of fewer resources and some greater uncertainty. So the quality payment program that MACRA implemented had a number of goals, and I think these are important because these really also underlie the alternative payment programs, which is one of the components of MACRA. MACRA was designed to try and improve care, produce better outcomes, and decrease some of the regulatory burden of existing programs that were value-based. And clearly, MACRA was designed to try and encourage the use and adoption of alternative payment models. Those are models that align incentives across not just the Medicare program, but Medicare with Medicaid, with commercial payers and others. MACRA made a number of changes, including repealing the SGR, Sustainable Growth Rate, but importantly, it really provides a roadmap and a timeline for migrating to risk and aligning Medicare fee-for-service practices and risk practices with commercial and Medicaid programs. It does that through two alternative pathways that are available to be participated in by eligible clinicians, those being doctors, nurse practitioners, PAs, and others. One is called the merit-based payment incentive system, and I'm going to talk briefly about that, and then the other is this alternative payment model system, which is the bulk of our discussion today. The merit-based incentive payment system, or MIPS for short, it basically is the default. So if a physician or other eligible clinician, such as an NP or a PA or a doc, is not participating in an alternative payment model, they are going to then be subject to potential plus or minus adjustments to the fee-for-service reimbursement that they get for their professional services. 2017 was a transition year, and so we're still in the midst of that. CMS made it such that people can avoid penalties by simply reporting one measure. And in the proposed rule that was recently published dealing with this program, CMS also proposed to further reduce the number of physicians and eligible clinicians that might be subject to payment reductions. That is consistent with the administration's approach and efforts to try and reduce administrative burden and complexity. That said, by law, by statute, under MACRA, there are statutorily imposed payment adjustments, and those are mapped out on this slide where we indicate the performance year, meaning in 2018, how physicians and other clinicians do in 2018 will impact what their employer tax ID gets paid for their services in 2020. And that can result in a plus or minus 5% adjustment to the fees. And that changes over time. The second prong is a program that clinicians can opt into, and this is the alternative payment model and advanced APMs model. this track is designed to, as I said before, try and encourage health systems and their clinicians and then just clinicians in independent practice to move into more value-based arrangements that involve risk. And there are some carrots for that. There is, as this indicates, a lump sum 5% bonus if a clinician is participating in an advanced APM. And it's merely participation. So for example, if the advanced APM didn't actually save any money, for example, the eligible clinicians participating in it still get a 5% bonus payment. Clinicians participating in an APM, and we'll talk a bit about common APMs such as ACOs in the Medicare program, those clinicians are exempted from the MIPS reporting and payment adjustments. So participation in these entities avoids those potential negative penalties. And then lastly, beginning in 2026, the Medicare physician fee schedule provides a financial carrot for participating in an advanced APM. And that's to also help migrate the community and provider community to APM models. Advanced APMs have certain requirements that are summarized here. They require use of certified electronic health record technology by a portion of the participating providers. The programs themselves have to have quality measures, and so we'll talk a bit about the Medicare Shared Savings Program, for example. And then importantly, the payment model with CMS needs to actually involve financial risk or involve a medical home model. And so the Medicare Shared Savings Program, ACO model, different tracks, that's one of the most commonly used programs by health systems. Those models will work and potentially qualify as advanced APMs in the near term, and then other payers get added down the road. And consistent with the idea of trying to encourage greater participation in these programs, the number of patients and the sort of the connectedness of these organizations, ACOs for example, to their eligible patient populations tends to increase, and those are the numbers down at the bottom. We can talk more about that in a few minutes. I think from a hospital and a health system perspective, I guess as I think about this, there's a couple of really important points. First is that hospital employment and health system employment of physicians has clearly become more normative than it was a few years ago. Now 1 in 4 physicians are employed by hospitals and health systems. That said, there are significant operating losses being experienced in those organizations. The AMGA projected in 2015, they said that the losses were $210,000 per FTE clinician or physician. I suspect that the people on this call have varying experiences, but in most instances there is some net operating loss. Hospitals also are subject to the value-based payment incentives that we've talked about, and those have significant implications on many hospitals. And then just if we were to think about a sort of a hypothetical physician group that might be hospital affiliated or hospital owned, in this instance I sort of asked the question, well, what if we had 200 doctors, 70 of whom were primary care, 40 of whom were other specialties that were in fact subject to MIPS, and 20 of whom were cardiologists, which I suspect is similar to many of the organizations on the call. And what if we did poorly under MIPS? What would the financial implications be? And that's shown on here that based on those providers, the health system could stand to lose almost $2.5 million by 2022. And obviously everybody's performance would vary. But I think it gets to the point that performance under MACRA, avoiding the MIPS payment adjustments, and succeeding under alternative payment models is going to be important. And how to actually strategize and be successful under these APMs is a very important point that that we're going to kind of talk about, at least the experience of one health system here for the next few minutes. Strategy is this concept of a plan of action, and in my view, as you're mapping out a strategy and a plan to participate in alternative payment models, you actually need to think about sort of where you are today, and then what's the timelines and the requirements that it's going to take to get to where you're trying to go. One of the themes that I think will come through in Dr. Robertson's discussion is that you don't really get there just by starting today and being done tomorrow. It's a journey that takes quite a while to move forward. And so with that, I'm going to tee it up to Dr. Michael Robertson to talk a little bit about the experience at Covenant Health System in Lubbock. Dr. Robertson?
Thanks, Bruce. Let me tell you a little bit about Covenant Health System. We are basically a health system within a health system. We're part of Providence St. Joseph Health. Covenant has its own entities within it, but we became part of Providence St. Joseph Health in July of this last year when our previous parent organization, St. Joseph Health, that was headquartered in Irvine, California, merged with Providence Health and Services in Renton, Washington. We're now the third largest not-for-profit health system in the United States. We have in Providence St. Joseph Health now 50 hospitals, 829 clinics, 23,000 employed physicians, 106,000 caregivers, as we call them. They have over 1.9 million covered lives, and we span multiple states, including California, Alaska, Washington, Montana, Oregon, and Texas and eastern New Mexico. Covenant Health is responsible for Texas, West Texas specifically, and eastern New Mexico. We have our large flagship hospital, which is Covenant Medical Center, which is based in Lubbock. We also have 4 other acute care and specialty hospitals, including the region's only freestanding children's hospital, a long-term acute care hospital, a freestanding inpatient rehab hospital, a smaller hospital in Plainview, Texas, which is a community about 40 miles north of Lubbock, and we also have an acute access hospital, which is located in Levelland, Texas, which is about 35 minutes west of Lubbock. We have a total of about 977 licensed beds through those facilities, and we have 600 physicians on our medical staff. Our catchment area is enormous, and that is part of the problems we have with having a clinically integrated network and trying to be responsible for care. We have a 62-county service area in West Texas and eastern New Mexico. In essence, it's about 60,000 square miles. About 1 in 4 of our hospital admissions are from eastern New Mexico, where we have no hospitals, but we do have some satellite clinics in those areas. The geography of New Mexico is such that in eastern New Mexico, it's easier to come east to Lubbock for medical care than to cross the mountains and go to Albuquerque. And so we see routinely a lot of people there. We helicopter people in. We also have fixed-wing air service to bring people in. We do have employed physicians. Covenant Medical Group is our employed physician arm. There's roughly 200 or so physicians in that group at any given time, and that number fluctuates. Covenant Health Partners is our clinically integrated network, and Covenant ACO is our accountable care organization. Change to the next slide, Bruce. This is just a schematic of what we talked about. You can see Providence St. Joseph Health at the top, Covenant Health System below that. Covenant Health Partners was created in 2007 to begin to clinically integrate physicians and to try to tie physicians a little bit more strongly to the health system. Quite honestly, when we started this organization in 2007, we had no idea that MACRA was coming and some of these other changes in physician payment. But it turned out to be a very fortuitous decision that we made, because it has helped us in a lot of ways get prepared for what is now being implemented. Covenant Health Partners is basically comprised of about 369 physicians, part of whom are employed directly by Covenant Health, but the rest of whom are independent groups. and they range in size from about 2 to 7 physicians. Outside of the medical group that's employed, we do not have a large physician organization. So we're dealing with a lot of different physician groups and a lot of tax ID numbers. We created Covenant ACO in 2014 when we got into the Medicare Shared Savings Program, because we had to have a separate entity for that, and that's the schematic that's there. So you can see all those different parts. The only thing that isn't on that slide, which probably should have been, is we also get to participate in CJR, the Comprehensive Care for Joint Replacements. We were one of 67 MSAs nationally who was, quote, randomly chosen to be part of that program, and so we have that going for us as well. Next slide, please. Several things came up in terms of our journey to where we are now, and a lot of it did have to do with strategy. Again, we formed Covenant Health Partners in 2007. There was an initial attempt in 2006, but it did not go over well due to some lingering distrust with physicians in what was then the existing hospital administration. We went through a series of multiple administrators, which was very difficult as well. But in 2007, we were able to form Covenant Health Partners, and then about 2008, we began our first contract, which was a hospital efficiency contract to help protect Covenant Medical Center against value-based purchasing penalties. And that program has been fairly successful, and we have managed to do fairly well with that. The only penalty we have right now is a fairly small one for readmissions for total hips and total knees, but we've managed thus far to avoid any of the other penalties, and by and large, the value-based purchasing Covenant Medical Center has come out very well from a financial standpoint, and we think it's in no small part due to this hospital efficiency contract that was started in 2008. We started doing other gain-sharing agreements after that with different insurance companies. We now have arrangements with Blue Cross Blue Shield, United Healthcare, and also First Care, which is a regional health insurance company that is a majority owned by Covenant Health, which also provided a leg up for our organization because we basically already had that risk. Covenant Health had that risk as a whole anyway, and it allowed us to kind of begin to play in that sandbox as physicians and to begin to understand the implications of what these payment programs might look like as time went on. About 2013, we began to look at whether or not we ought to be pushing ourselves a little harder, and we did make the decision to get into the Medicare Shared Savings Program, and we started that January 1st of 2014. We went in under Track 1, and the main reason we did it is because we suspected that that was coming, and we knew that if we didn't just go ahead and do it, that we wouldn't do it until we were forced to do it, and we wanted to kind of learn as slowly as we could and as painlessly as we could. And we've been reasonably successful under Track 1. Covenant ACO was created for that Medicare Shared Savings Program, and we retained Covenant Health Partners structure for our commercial products. In 2016, we were in the last year of our 3-year stint under Track 1 of the Medicare Shared Savings Program, and this program called MACRA was beginning to surface. And the more we looked at that, the more we realized that that was a true game changer in terms of physicians, because for physicians, it's basically analogous to what value-based purchasing did for hospitals. It suddenly makes physicians responsible for the quality of care they're delivering and also the cost of that care. So the more we looked at MACRA, the more scared we became of MIPS, and so we decided we wanted to do, as an organization, everything we could to see if we could qualify as an advanced APM. We began looking at Track 2 and Track 3, and ultimately our board, which is comprised of 19 physicians, made the decision to move from Track 1 of the Medicare Savings Program to Track 3 of the Medicare Shared Savings Program, and we began that in January of this year. Next slide, Bruce. Organizational concepts had to be changed as well. Like most health systems, we were in an incredibly siloed organization. People were working on a lot of things and nobody knew what anybody else was doing. And sometimes we ran into conflicts in terms of trying to execute on strategies. One of the things that we realized very quickly is that even our inpatient care coordination programs and our outpatient care coordination programs were not in synchrony. We had a lot of problems with handoffs. When people would leave the hospital, we thought we had a fairly good plan, but it fell apart relatively quickly after they left the dismissal driveway, and then we didn't have any good way of doing service recovery. So one of the first things we did, dating back to 2015, was to bring in a consulting company to help us restructure our organization. We thought we might be able to do it internally, but we realized fairly quickly that it was well outside the scope of our abilities. And so we brought in Southwind to do that for us. And we identified everybody that was providing care coordination within the system and basically put them under one organizational structure that reports up to a vice president for enterprise care management, who is a registered nurse and also has a PhD. That individual has been incredibly helpful in terms of providing some synergy between our inpatient and outpatient care. And now our inpatient care managers and our outpatient care managers have a better understanding of what each one does, and we do a much better job of providing handoffs in terms of transitions of care. We also, as part of our participation in the Medicare Shared Savings Program, began to get fairly detailed financial spend reports from CMS regarding the 13,000 or so people in our Medicare Shared Savings Program attributed population. And the more we looked at that, the more we realized that we really weren't all that bad in terms of what we spent in the hospital, and certainly our physicians on an outpatient basis were spending less than the national average. But what was really hurting us substantially was our post-acute care facilities in town. We identified that our skilled nursing facilities accounted for a spend that was 187% higher than the national Medicare fee-for-service average, and our home health care agencies were even better capitalists in that they accounted for a spend that was 250% higher than the national average. So one of the first things we began to do, dating back to even 2014, was asking our post-acute care providers to begin sharing financial data with us, which they did. We had contracts developed by Bruce and his firm that worked out how we would do this and what our intentions were, and they were comfortable with that. And we began to share data with them back and forth without even mentioning what the end game was, but I think they understood that at some point we would be going towards a more narrow network. Over time, we developed a strategy where we began to look at very objective measurements that we could get from CMS and other entities to kind of rank home health care agencies and skilled nursing facility agencies. And in January of 2017, we developed a narrow network which now consists of 4 skilled nursing facilities and 5 home health care agencies that are actually have a signed contract which outlines our expectations for them, and that includes the ability to take transfers on any day of the week, including holidays, having an RN on service at all times, and other sorts of things, and we provide some information to them. Even before we created the narrow network, we began to notice in 2016 a consistent downward trend from quarter to quarter in 2016 spend in both the skilled nursing facilities and home health care agencies. We also began to look at our IT systems. They were woefully inadequate, and one of the biggest investments that we made was for an electronic data warehouse that gets data from Meditech, our inpatient electronic health record, Allscripts TouchWorks, which is our outpatient record for our Covenant Medical Group, which has 70% of our primary care physicians in it, and it also contains other sorts of feeds, including financial feeds from Medicare and our other payers to give us a better idea of where we're at. At this point, we have a physician dashboard that's been developed, and a physician is expected to at least once a month log in. He can look at his data determine which contracts he's missing metrics on, and begin to drill down into that data to such granularity that he can actually see patients and patients' names that need a specific metric met for that contract, whether it's a diabetic, if it's a hemoglobin A1C or a microalbumin level, whether they need breast cancer screening, whether they need colon cancer screening. We also now have an operational dashboard for our post-acute care network where we can monitor them on an ongoing basis and see what their readmission rates are, what their ED visits are like, if people are coming from skilled nursing back to the ED or from home health. So it provides us a better opportunity of being able to monitor our network. Go to the next slide, Bruce. Financial systems, also a big issue for us in that we began doing these clinical integration initiatives. As I said, we started out with a hospital efficiency program contract. We are now responsible for Covenant Health's employees and their benefits. There's around 9,000 of those folks in that contract. It's self-funded. We use First Care as a TPA to pay the claims, but Covenant Health is on the hook for that program. In our first year of implementation of that, we saved Covenant Health $4 million in spend without really doing a whole lot of things, and we continue to try to help them adjust their benefit structure and work hard towards trying to provide the most cost-efficient care that we can while yet maintaining very high-quality standards. We've also engaged with other third-party payers to do different sorts of things for us in terms of gain-sharing agreements. The Texas Retirement System is one of those contracts. It's administered now by United Healthcare. It will transition to Blue Cross Blue Shield in September. It contains 7,000 or 8,000 lives that are attributed to our population. We also have a contract now with Blue Cross Blue Shield that just started this year. We have a large Medicaid, managed Medicaid contract that we have, and right now we have a little over 77,000 lives under contract through our different initiatives out there. And we're looking at other opportunities to expand our reach throughout this region and perhaps even throughout the state of Texas. The Medicare Shared Savings Program has been a big help to us because it's helped us understand where all of our spend goes. I think that's one of the biggest benefits that we had. We didn't recognize it at the time, but the amount of financial data that you can get from that really helps you understand where the spend is going. And it's very clear that Medicare wants us to be responsible for the absolute total spend. The Medicare spend per beneficiary is a very important number, and it gives us for the first time the opportunity to see where that money is being spent. And by delving down into that, we can actually begin to see which organizations and sometimes even which physicians may be causing us some heartache, and then to begin to derive some strategies and tactics to try to reduce that spend to a more appropriate number. As you might guess, there is a tremendous amount of waste in the healthcare system, and just removing that waste can provide a tremendous amount of savings. In 2014, we were subject to the first year under the MSSP. It was a reporting only. All we had to do was report our data. We had a very huge financial impact. We saved Medicare $5.2 million. So we got a $2.6 million windfall payment from MSSP without really having to perform other than to hit a financial target. In 2015, we did not receive an incentive payment from the Medicare Shared Savings Program. We did have savings of about $1.28 million, but our threshold, which is about 2.79%, I think, under Track 1 of the Medicare Shared Savings Program, you have to achieve that much of a reduction in your overall Medicare spend to even be eligible for an incentive payment. And our threshold that year was about $4.3 million. We have received information from Medicare about 2016, but that's embargoed, and we can't speak about that. But overall, we've been very pleased with the way we have performed under the Medicare Shared Savings Program, and that also gave our board the confidence to make that leap of faith to transition from Track 1 to Track 3. Go to the next slide, Bruce. This is a slide I think that's been taken from the advisory board, which kind of shows two different loops as to how to transition from volume to value. Our health system struggles mightily with how we do things because things have been set up over time to take advantage of volume. And now we've got this organization called Covenant Health Partners that's poked its nose in the tent and is beginning to upend the apple cart. So it's a very delicate balance as to how you move in one direction or the other. This chart basically shows two different curves, and what I'll tell you is we've never landed long on either one of those curves. We hop from one side to the other. Again, we kind of led with the philosophy of let's get some contracts and let's see if we can practice enough to be good at this, and now suddenly we're in the risk-taking business, and we think that's going to pay off for us. Because again, the ultimate decision that our board made was, dadgummit, we know it's happening at some point in the future, and we might as well just get it over with and get good at it while we have the opportunity before we really get ourselves in so deep that we can't make the necessary changes that we need to make before it's really, really hurtful. Move to the next slide. This is a slide that St. Joseph Health was famous for utilizing. This was population health, was a big initiative of the St. Joseph Health System. As you might imagine, it's very centralized in Southern California especially, where there is a lot of managed care. But we've always embraced population health management. We're very involved as a faith-based organization. This is a Catholic ministry, as is Providence St. Joseph Health. And so we're always looking to take care of the poor and disenfranchised in the community. While we have a county hospital that's responsible for indigent care, I will tell you Covenant Health has indigent care expenses that are a multiple of about 3 times more than what the county hospital spends, and they get a $21 million tax levy that offsets what they're spending. So we take care of the poor in our community, and what we've endeavored to do with all of our projects and strategies and tactics is to develop and implement a sustainable care model that takes into the account the disenfranchised in the community, the poor in our community, to try to build healthy communities, deliver the best care that we can, and to foster what we call sacred encounters, again, with our faith-based beliefs. Covenant Health provides 10% of our overall profits each year to our community benefit program. It goes to the poor. We have a dental van that we use to rove around and treat children that couldn't afford to see the dentist otherwise. We have mobile mammography, and we have numerous other projects that are within the community to try to treat the poor as best as we can. Next slide. This is a vision that we put. We had a 5-year plan starting in 2014 to 2018 that said we would be at risk for 100,000 members under population health management contracts. We're well on our way to getting there. We have 77,000 now. We do have 90 primary care physicians in both CMG and our affiliated physicians. We do try to keep our network bleed very low. We're the dominant healthcare system in this region, but we want to make sure that our care stays within our network because we believe that it's very cost-effective care, and we have some programs in place that help us rein in costs while still delivering high-quality care. Go to the next slide. This is basically one of the things that we developed years ago to kind of show our physicians and show others what Covenant Health Partners was all about. We have basically 4 cornerstones. Physician leadership and influence is absolutely important. If your physicians aren't bought into this, it's never going to work. Again, we are chartered under the state of Texas as a 501A organization under the Texas Medical Board, and that means our board has to be all physicians. We have 19 physicians. About 50% of them are primary care. We would like to, over time, stack that to where it's probably along the lines of 70 to 80% primary care, because most population health efforts impact primary care the most. They elect their own members. They are not appointed by Covenant Health, even though it owns Covenant Health Partners. It has the right to remove a board member if need be, but the physicians govern themselves. We are all about chronic disease management and education. predominantly diabetes, COPD, and congestive heart failure. We also are very heavily into measured performance and reporting. Our electronic data warehouse and our physician dashboard that's been developed is absolutely paramount to our success, because if our physicians don't understand how they're performing on contracts, they're never going to change their behavior. So we have really done everything we can to provide them electronically a report card that is as accurate and up-to-date as humanly possible. We also have the advantage of having systems built out to help us provide that care. Let's go to the next slide. This is another way basically of looking at that last slide, and I won't dwell on that much. Some of the information on that slide, like the number of physicians and the number of PCPs, is actually a little outdated. We do have several physician committees. We have a board of directors. We have a credentials committee. We have a quality and performance committee that does peer review and monitors metrics and physician performance on those metrics. And we also have a population health committee that is more strategic in nature, and it's very heavily loaded with primary care physicians. We utilize risk stratification techniques. All of our patients that are under contract are risk stratified from the get-go, and we begin to work with those that are at the highest risk. We're looking at chronic disease states. We evaluate all of those people for psychosocial issues that might impair their ability to provide self-care and work on things to try to empower those patients to overcome those things. We look at efficiency opportunities across the continuum of care. We have access to claims data, other sorts of quality data that helps us, and then we have people that actually reach out to our physicians and try to help them understand where we're at and where we're going, and find out if there's some things we could do to help them more directly. Let's go to the next slide. It basically shows our care coordination staff, and it has grown fairly significantly over the past 3 years or so. We have a director for our outpatient care coordination. This is just for outpatient. On the inpatient side, we have about 50-something people working there as well. But our director is a MSN. She's been with our organization for several years. She has 2 managers. One is a licensed master social worker, and the other is an RN. The social worker oversees our commercial contracts, and the RN has to do with DSRIP, which is a Medicare waiver program in the state of Texas, and our Medicaid and CHIP populations. You can see the others that are broken out. What you'll notice is that we make use of RNs very heavily. They are team leaders, period. They have the clinical expertise and the other expertise to lead these teams and to identify the people that we need to be working on, and they do a very good job of that. Next slide. In terms of coordinating care, I showed you that we assign risk scores to all of these people. We derive these risk scores in different ways, but we try to risk stratify folks because the top 5% of patients, which we call the high risk, is responsible for 80% of the spend under a contract. These are folks with complex diseases and multiple comorbidities through no fault of their own, although sometimes it is through their own fault because of risky behaviors that they engaged in, like smoking many years ago and eating excessively. We try to manage those people as heavily as we can through our care coordination programs. The rising risk patients are those folks who have health problems that are going to become a problem for them. They haven't recognized it, and perhaps we haven't either. But through the use of analytical tools, we can identify this 15 to 35% of that population and try to prevent them from moving up into the high risk. About 60 to 80% of the population, they're healthy folks, and all we try to do is keep them healthy and loyal to the system. We want to keep our brand in front of them and do everything we can to try to continue to engender their loyalty. Next slide shows you what we actually do with those high-risk patients. I won't go into that in detail because it's fairly self-explanatory, but that's basically the things that our RN and the members of that team do for that group. We want to try to get all those people a PCP if they don't have one. We do still have some third-party payers out here that do not necessarily require a PCP be designated. Our Medicare Shared Savings Program patients do not. A lot of them just see subspecialists. And so one of our goals is to try to get them a PCP. We provide as much education as we can for those group. We also work very hard to help those patients set goals for themselves and then try to hold them accountable to those. We do medication reconciliation. We always verify that they are in the appropriate risk group. And again, one of the things we do is we screen everybody for depression because if they have depression or some mental illness, their spend is going to be higher than it would be otherwise. They just can't engage in self-care. The next slide actually shows you some other ways we do that. We have feeds from Meditech that alert our care coordination staff within 5 minutes of a contracted patient hitting the emergency department or whether they're admitted to the hospital. We know, and we can go see them in the ED or see them as soon as they've been admitted and try to begin to work on discharge plans along with our inpatient care managers. Our clinics, our individual physicians can electronically or by telephone or by fax refer patients to our program. We also do cold calls on those folks that are high risk that have not been sent to us otherwise. The next slide basically shows you what we talked about in terms of bringing all of care coordination under one group. We now have a centralized care management enterprise, and you can see the bidirectional arrows going back and forth between Covenant Health and that. Covenant Medical Center, our specialty hospital, Women's and Children's Hospital, our behavioral health units, all of those contract with us, and they basically pay us a fee that covers the salaries and benefits of all of these different people. In essence, what we did is our inpatient care managers were on Covenant Medical Center's budget. We transferred them to our budget along with the money to pay for that, and that's kind of how we paid for that system. We also interface heavily with First Care, which again is an insurance company that's majority owned by Covenant. It's 66% owned by them, and we do a lot of business with them, so we work closely with them back and forth to provide centralized care management. We have ongoing conversations with them once weekly talking about patients that are in the hospital and other high-risk patients to devise plans to best manage those patients. And with that, I'll turn it back over to Bruce.
Thanks very much, Dr. Robertson. That was great. So that, in my mind, that was a great sort of under-the-hood analysis of a functioning clinically integrated system, as well as their strategy and their approach to alternative payment models. I'm going to quickly go through just a few other slides and then leave a few minutes for questions. This slide is kind of a combination of one of the slides that we saw earlier, which shows the potential payment penalties under the MIPS program, under MACRA, or the Quality Payment Program, combined with the alternative payment model, number of patients or percentage of patients or payment that needs to come through an ACO or a similar organization. The highlight on this, the reason for this slide is that I think it does provide a timeline, if you will, and illustrates the importance of doing something to get into this space sooner rather than later for those health systems that may not be actively engaged in this space. And part of the reason for that is if you look at this payment or patient count threshold, those are requirements that basically under the Medicare Shared Savings Program, if there is an alternative payment model, the clinicians that are engaged in that model need to ensure that the care that their patients receive really is pushed through the alternative payment model. So using, for example, the Medicare Shared Savings Program as an example, over time, the portion of the care that is received by the Medicare patients seen by that ACO, where the care is provided by the ACO's affiliated providers, needs to increase over time. And really what that means in my mind is that the early bird gets the worm, or those, putting it another way, those that wait too long will find that it's difficult, if not impossible, for them to actually create a successful model on their own, and what they may do is find themselves having to participate in someone else's. we've talked a little bit about the Medicare Shared Savings Program, but this slide is designed to at least illustrate some of the advanced APM models that will be available in 2018. And I'll let you all study this slide after the webinar, but one of the key takeaways on this is that you can actually have a combination of different models. So for many health systems, using the ACO structure, because of its multi-specialty nature, makes a lot of sense because it allows for engagement with the medical staff. But you can have also other alternative payment models, such as the oncology care model or some other models, and actually use those and combine them with your existing, with an MSSP structure. And one of the things that I think is really important that Covenant has done that not all health systems do is that I think they've done a really good job of trying to, in essence, use the clinically integrated network and the ACO as the hub for these types of value-based activities, rather than having, for example, multiple co-management agreements that are one-off deals and sort of each organization doing their own thing. I went too far. One other thing just to make you aware of is that MACRA also approved what's called the physician-focused payment models. And these are basically models that clinicians and organizations can actually propose to CMMI in part of CMS and have a program approved as an alternative payment model. So when you're looking at some of these alternative payment models that exist today, if there's something there that doesn't meet your needs or you don't like, I think actually that CMMI and the administration now are actually enthusiastic about trying to work with the provider community and states and others to try and come up with something. And so physician-focused payment models are another option in that space. And then perhaps the last point before we go to questions is that there are absolutely timeline considerations. And just as I said earlier that the early bird gets the worm, those that wait too long will have challenges, I think. And I think looking at and understanding the timeline on moving through these alternative payment programs, for example, in mid-2018 is the date that you need to actually have applied to participate in the Medicare Shared Savings Program in 2019. So that's merely about 8 months away. And other APM programs have similar timelines. You've got other activities that kind of align with these timelines, like open enrollment periods, state and other benefit plan open enrollment periods, and any number of things that as a health system is thinking about strategically, how do we succeed in this alternative payment model environment, and how do we avoid getting stuck with the MIPS payment penalties and potential wins, thinking about the timeline and recognizing that you really need to plan, at least in my mind, 18 months ahead. I think that's a critical takeaway. This is a suggested sort of illustrative timeline for a hypothetical health system, and it just kind of lays out the concept. My view is you need to have a strategy that sort of assesses where you are today and then how you're going to roll into this over time. And then there are other slides here that talk about topics that I'm going to leave alone for right now because they primarily focus on some of the innovative structures that we're seeing many of our clients look at and consider of how do we actually align incentives related to compensation and get off of perhaps the RVU-based models that some systems have. And so we'll go to the final slide here, and I think that the takeaways before we go to questions are that all of this takes time. Covenant Health Partners has been around for several years, almost a decade now, and they're still in the process of learning, but they used that time well. Participant engagement is important. The Medicare Shared Savings Program provides important data, and on all of these points, there's a lot of opportunities, but the time to actually get going with them is probably now. If you haven't got started, you better get to it, as the saying goes. So with that, let me turn it over to questions, and we'll leave the rest of the slides for folks to look at after the webinar.
Great, thank you for that. Well said. Rome certainly was not built in a day. So I want to thank Mr. Johnson and Dr. Robertson for your both of your complimentary perspectives on this very timely topic. Now, before I take our first question, I would like to just remind everyone to type their questions into the questions chat panel located to the right of your screen, and we'll take as many as time will allow. I will address one question about the slides. If you missed the initial announcement, you don't have to wait. You can get access to the slides immediately. There is a handouts panel also to the right where you can expand to and click on the PDF icon to access these great slides. All right, so let's jump right in here. I think the first question is for Dr. Robertson, and it reads, our health system has not elected to apply for and participate in the Medicare Shared Savings Program due to the amount of regulatory burden. Do the benefits of participation outweigh the burden?
I think the best answer to that question is that it depends on your perspective and where you are along this continuum. If you don't have a clinically integrated network of physicians and you've not done any of these things, probably jumping directly into the Medicare Shared Savings Program may not be your best choice. Even into track one, because it may do nothing more than just frustrate your physicians. If you do have a fairly advanced network, though, again, I think the benefits is that it does prepare you for what's coming down the pike. I think looking at the way MACRA is structured, it's very obvious. They want physicians and hospital systems, medical groups, they want us all to be taking risks. They don't want, CMS does not want to be the only one who has money at risk in this thing, and they're going to push us into that in one direction or the other. And I think that's the reason that MIPS is as punitive as it is, and that bar is going to change every year. You might perform well under year one of MIPS, but because everybody else begins to perform better, the second year you may get a decrease in your reimbursement from Medicare. So you never know what you're going to get. So I think at some point you need to take risk, and certainly even getting into some of the early tracks, like track one of the Medicare Shared Savings Program, just the benefit that you get from seeing where all that money is being spent, there is a treasure trove of information there, and it applies to commercial projects as well. So having access to that data really does open your eyes about where you may be able to restrain some cost and how you can squeeze some profits out of a clinically integrated network.
All right, thank you for that. I have another question for Dr. Robertson. This comes from Brian, and he asks, have you taken advantage of the CMS Chronic Care Management Program with CPT code 99490, or are you relying on the Medicare Shared Savings Plan for compensation for chronic care patient plan compensation?
We have no single strategy at the Covenant Health Partners level for that. We've tried really hard to engage our employed medical group in doing that. They've dragged their feet a little bit with it, but we have several independent physicians that's what they're doing. They're billing for the chronic care management codes. You know, one of the other things that we have taken advantage of is in our participation in the MSSP Track 3 is we have applied for and were granted the ability to waive the 3 midnight rule for skilled nursing facility admissions. So we now have a process in place where we can admit patients that need just skilled nursing that don't even meet criteria for admission to the hospital. We have the ability to send them directly to skilled nursing from the ED, from physician offices and other places, and that's resulted in some cost savings. Generating money through the CCM codes, though, does make sense. We are using the transitional care codes also very heavily to try to help increase some revenue to help pay for some of these programs.
All right, thank you for that. Okay, it looks like we've already run out of time, and I do want to be respectful of everyone's schedule. So just before we depart, I'd just like to share a couple pieces of news going on from the HFMA chapters. We have next week on 9/20, they are hosting a 2-day fall retreat, and registration is still open for this educational event. Then in October, they are bringing back the popular Medicare Boot Camp series. You've probably heard of this type of education platform at various locations throughout the U.S., but HFMA Region 10 is offering the same content from the comfort of your home or office computer. So to learn more and register for this and other upcoming events, be sure to visit hfma-co.org. So thank you once again to our guest presenters, Mr. Johnson of Polsinelli and Dr. Robertson of Covenant Health Partners. We hope that you will join us for our next webcast, and be sure to participate in our exit survey, which you'll automatically be routed to, so you can let us know of some other great topics that you'd like to see in the future. Thanks everyone, and have a great afternoon.